Welcome to the Lumbar Spine lecture in Musculoskeletal 1, Orthopedics. This is intended to give you a nice overview of the anatomy of lumbar spinal motion, as well as some of the biomechanical aspects of the lumbar spine, as well as a general overview of a couple of basic dysfunctions to prepare you to learn more about the lumbar spine. First thing I'd like to cover about basic spinal anatomy is that idea of the spinal motion segment. This is really the basic functional unit of the spine, and we refer to the halves of two vertebrae, the disc and the facet joints. It's really referred to by the adjacent levels, such as L4-5 or L5-S1, much more so than individual vertebrae. The spinal motion segment includes everything else in the space, such as nerves and blood vessels, nerve roots, muscles, and ligaments. The spinal motion segment has a number of different functions, which include that of weight bearing. It protects the spinal cord and provides for motion, which is controlled by the spinal anatomy, which basically guides the motion in a number of different directions. That motion can be guided by bony elements, by ligamentous structures, or muscles. When we name the motion of the spine in reference to segments, again, it is in terms of, say, the L4, L5 segment, referenced with the smaller number on top. This is just a small pictorial of the spinal motion segment. You see in between the two lines is essentially how those vertebrae interrelate with each other, and that is the spinal motion segment just in between the two halves of the vertebra, with the nucleus of the lumbar disc as seen in between the two bodies of the vertebra. The intervertebral disc, or just referred to as the disc in this case, makes up about 25% of the height of the spine overall, 33% of the lumbar spine. The discs are much thicker and take up more volume and height in the lumbar spine. The function itself permits motion, guides motion, and they work much like ligaments that also limit other portions of the body, such as the ankle. So it's important to realize that the disc itself actually restricts movement as well as permits motion. It's important to know that the disc itself really functions more as a transmitter of shock. It's filled mainly with water is the primary substance, and we all know that water itself is not a good absorber of shock. Say if you were to jump in a pool and do a belly flop, you realize that that is not a soft, cushy landing on that surface of the water. So essentially, the water content of the disc transmits shock much better than it absorbs shock. So that's a common misconception or an oversimplification that a lot of healthcare practitioners will often give their patients. The two components of the disc include the annulus fibrosus or the nucleus pulposus. The annulus being the outer rings of the disc, or the outside of the jelly donut, quote-unquote, and the nucleus being the water-filled center of that disc. I'll be covering much more of the function of the intervertebral disc later on in this lecture. This is a cadaver picture of a lumbar spine, and the arrow is going to an intervertebral disc. One thing you should pay attention to is how those first three discs on top have some pretty good height left to them, where if you look at the L4-5 disc, which is the fourth disc down from the top, actually doesn't appear to be in as good a shape as the other discs. The height is decreased, and it looks like there is a reduction in the nucleus, which would normally create most of the height within the disc. So we could assume that this one might be a bit more degenerative to that L5-S1 motion segment. And here is another artist rendition of a lumbar vertebra, as well as the intervertebral disc, which is cross-sectioned on top. The arrow that you see is depicting some fissuring of the annular rings of the disc. And this is essentially how it's believed that the lumbar disc begins to degenerate, as there is a breaking through or a deterioration of the annular rings, which slowly allows the nucleus of the disc to slowly migrate its way out of the posterior annulus. This pictorial here is a look at the different zones of the intervertebral disc. Number 1 on this picture is really the nucleus, or the inner gel-like substance. So here we're looking at a vertebra above and a vertebra below, and this disc is between those two vertebrae. Number 2 is the annulus on the outside. It's made up of an average of 6 to 10 concentric rings, or fibers, which have their arrangement in an oblique fashion. So one will have rings running in one direction, and the next ring will have fibers running in another direction, more in a diagonal. So they run at angles to each other and not completely up and down. This is a look at the annular rings. As you start looking from the outer portion and going in, you can see the oblique angles, which you couldn't see in the previous picture. As you get closer to the center, it becomes more mesh-like in orientation. If there's an injury to the outer annulus, it is possible that it will heal because there is blood supply to that area. Oftentimes people think that the nucleus is injured first and it migrates out, but that is usually not the case. Usually the problem occurs at the outer rings, such as one of those previous pictures with that fissuring from the outer rings. It begins to tear. The disc in and of itself usually heals within about 6 months, progressing well, and at 12 months, as long as no other abnormal stresses are placed on it, it should be pretty well healed. The only problem is that patients often don't realize the significant abnormal stresses that they place on their spine. Therefore, their healing may be significantly impaired if education is not properly administered to the patient. The nucleus itself is hydrophilic, meaning that the material inside of the disc is water-loving. The disc itself enjoys nutrition through fluid diffusion, or so-called imbivision. Rather, the imbibing of fluid comes from the vertebral end plate into the disc. So it's really the weighting and unweighting of the disc that brings this fluid and its nutrients into the disc. So when we lay down at night, the compressive body weight takes its forces off the disc and it takes in water. And the result really is when you wake up in the morning, you can be up to 3/4 inches taller than when you go to bed. This also accounts for increased symptoms in somebody that has disc problems in the morning due to swelling throughout the night. As the outer annulus is innervated by the recurrent nerve, sinu vertebralis, you can get pain to that area when it's compressed, especially if it's swollen. It's generally accepted that the outer 1/3 of the disc is innervated. Being that the nucleus is hydrophilic, it's generally accepted that the disc cannot be reduced, meaning that if it herniates out through the annular rings, it can't be placed in because it usually swells by several times its own size. So it's like trying to push jelly back in a jelly donut. It would be quite difficult and almost impossible. This is a water or jelly-like substance, so you can see how this would be difficult. This is a artist rendition of an L4 disc. You can see the center of this disc would be the orientation where the nucleus pulposus lives. You can see the concentric rings labeled lamellae towards the upper left-hand corner of that disc diagram. And down through the right side, you can see the posterior and outer 1/3 of the disc being innervated. As you go down closer to the pars and the facet joint, you can see where the L4 spinal nerve root, the dorsal root ganglion, runs through the intervertebral foramen. This is a depiction of the disc receiving loads in several positions, predominantly the nucleus. So what's important to realize is that different positions will have different effects on the disc. Now the first picture all the way to the left essentially is normal. What happens when we're essentially laying down? There's an even distribution of forces here. The second picture is good, normal alignment throughout the day when we are upright. So the third picture is really an uneven load. Let's say the patient is essentially forward bending and it's getting squeezed in the front and the nucleus is getting pushed out the back. You can reverse this if you wanted backward bending. You can imagine that postural abnormalities or poor postures can lead to problems later. As you see the last drawing off to the right, you notice a torsional load. So this is essentially a combination of compression and shear forces. So in a torsional or twisting mode, because of the orientation of the fibers, only half of the fibers in the annulus will resist the motion. This creates a bit of instability when it comes to the restraint of these tissues. So if I twist to the left only, the fibers in that orientation will go tight, about 50% of them. So as a result, most discal problems will result in some type of rotational movement. One reason body mechanics and skills are so important for you and your patient is for this reason. So probably the worst thing that somebody could do, leaving their disc at risk for injury, is bending down to pick something up while twisting at the same time. So we'll see a lot of people with back problems that do work such as construction or luggage handling. It doesn't necessarily have to be anything heavy. This is a depiction of various nucleus positions with different loads, under rest, under load, backward bending, and forward bending. So essentially A is probably at rest when the disc would be imbibing fluid. B may represent us sitting in class listening to the lecture if we have great posture. However, C could be backward bending, and D could be that forward bending posture we might have while sitting with poor posture in class. Have you ever sat in class for a long time without a break, and then when you came upon time to standing up, you couldn't straighten up? You often hear that with patients, especially those with desk jobs that require prolonged sitting. It's very difficult to straighten up after you've sat or knelt for a prolonged period of time. Usually that occurs because the fluid is essentially squeezed out the front portion of the disc, and there's more fluid now in the posterior aspect. It's essentially more swollen in the posterior aspect. So now that you have an uneven distribution, it's going to be much harder to straighten up because it is more swollen in the back. It may take a few minutes for this to accommodate. This is a set of disc pressure studies by Nakomson. An excellent study. What's interesting about this is that these disc pressures were taken in vitro, and via these pressure transducers that were used to measure the intradiscal pressure, they found some interesting findings. First of all, one thing that seems reasonable is that the position being completely supine all the way to the left of the diagram was the position of least spinal pressure. As you see, as that person climbs up the stairs to higher discal pressures, as a person begins to stoop forward, disc pressures increase. What probably isn't all that intuitive is that sitting in good posture has a much higher disc pressure than, say, standing. Now, what increases disc pressure even more is the addition of a slumped posture, and especially picking up a weight in the seated position, giving the highest lumbar interdiscal pressures. So one thing, as a practical application, think about maybe all the times that you've worked out with a set of dumbbells and thought nothing of leaving that set of dumbbells on the floor prior to the exercise, and then slumping over and picking them up just prior to the exercise themselves. Knowing what you know and knowing intradiscal pressures, that might be something that you might want to modify from this day forward. Now let's take a little bit more of a look at the neuroanatomy. Most structures are innervated by 2 to 3 levels. This makes it kind of difficult to tell where the problem is coming from in our examination. If we have pain at the L4, L5 region, this pain could essentially be coming from one of the other adjacent segments. Now, when a spinal nerve root comes out, they are divided into both anterior and posterior primary rami. The anterior essentially go to the lumbar and sacral plexes. The posterior go to the facet joints, the outer disc, the muscles, the ligaments, and really anything else in the back. You're going to want to take a close look at this area of the lumbar spine and its neuroanatomical structures. The large structure that's being pointed to by the large colored arrow is the anterior primary ramus. This has a branch directly traveling from it anteriorly to the disc. Of interest is the posterior primary ramus coming off of this anterior primary ramus. This has branches to the multifidus and to the facet joint. These are of specific interest, seeing as though our founding president, Dr. Stanley Paris, did most of his work in neuroanatomy. One thing that's important to realize is that the posterior primary ramus does not have innervation to the disc itself. So again, take some time to look at this and to remember where these areas innervate. A concept that's extremely important is the relationship of the nerve roots to the disc. Remember, discs lie below the corresponding nerve root. Therefore, an L4 nerve root exits above the L4-5 disc. Therefore, the L4-5 disc will actually be able to impinge on the L5 nerve root. Similarly, the L5-S1 disc would impinge on the segment lower, being the S1 nerve root. You're going to find that stenosis is a much different case. This is a nice depiction, and it's a cross-sectional view in the sagittal plane. What's labeled there is the L4-5 disc space. What's important to realize is, again, the L5 nerve root is coming off above the level of the disc. You'll see it runs in perfect coordination with the disc, where if there were a disc pathology, such as a herniation, it would impinge on that nerve root. It's important to first know a little bit about foraminal stenosis. This differs from a disc pathology in that you already know that with discs, the nerve root exits far above where the disc comes out. With foraminal stenosis, it's actually some sort of an occlusion within the foraminal canal. It's usually an osteophyte or a bone spur, which is really just a small bony overgrowth in that area due to degenerative processes. Therefore, if you have something in the foraminal canal where the L4 nerve root is impinged, it's likely going to occur in the L4, L5 foramen. If foraminal stenosis was impinging the L5 nerve root, it's really going to be impinged right directly in the L5-S1 foramen. And that's simply because the stenosis happens very early on, as soon as that nerve root begins to come out of the neuroforamen. Again, with disc pathology, that nerve root is coming from higher above. Therefore, with a disc problem, it's going to affect the nerve root that's lower. This is further reinforced in the next slide. To further help you understand and remember stenosis versus disc problems and which nerve root it affects is the formula listed down below the asterisk line. So the L2 and the line and then the L3 represents the L2 and L3 disc, or the motion segment. So when you think stenosis over disc, if there is a stenosis problem, it's going to affect the L2 nerve root. And looking below, if it's a disc problem, it's going to affect the lower nerve root, the L3 nerve root. Above the asterisk line, if in an L3, L4 segment, you're going to notice that stenosis is also over disc. Therefore, if there is a stenotic problem at the L3, L4 segment, it's going to be an L3 nerve root problem. If there is a disc problem, that's going to affect the L4 nerve root problem. Remember, stenosis over disc, and that applies to spinal motion segments throughout the lumbar spine. A dermatome is a very essential component of your neurologic exam. It's something that you must know. Dermatomes are pretty general and widespread, and there's a little bit of variance between authors. But basically they're an area of skin that's supplied by an afferent nerve fiber of a single spinal nerve root. They run distal to proximal, meaning that they conduct information from distal to proximal. Now, when dermatomes are in the leg, we can say that pain is referred to the lateral thigh. It is not correct to say that pain is referred into dermatomes because it simply doesn't travel that way. So, in looking at this structure here, a good place to start is at the L2 region. While it's listed as the lateral thigh, this is kind of referred to as the region of the pockets. So if you were to put your hands and motion to put them in the pockets, you are in the L2 region. The rest of them follow as listed. Myotomes are another aspect of our neurologic examination that you must know. They're very important. So as you see listed, L1, L2 involve the hip flexors. Therefore, all you would simply do to test this myotome, or the strength in this area, is to flex the hip and do that against resistance. L3, 4 involves the quadriceps. This is done with just simply straightening the knee against resistance. L4, the dorsiflexion of the ankle, is related to the tibialis anterior. L5, extensor hallucis longus, is just extending the big toe. S1 is going to be the flexor hallucis longus and the peroneals. So we would simply flex the big toe and evert the foot. Finally, S2 involve the hamstrings, which are simply just a flexion of the knee. Now, a myotome is where muscles are innervated by an efferent nerve fiber of a single spinal root. What this will tell us is simply if there is muscle weakness, then we can correspond this to an appropriate level of innervation. Reflexes are an important component of your neurologic exam. We're going to be looking at the L3, 4 and the S1 reflexes, which are the patellar and the Achilles reflexes. You're going to learn how to do this more specifically in mock clinic. But really, when examining reflexes, you're looking to see if they are absent, diminished, normal, or increased. The patellar tendon reflex, or the knee jerk, is done to examine the L3, 4 levels. Now, if an L4 nerve root is involved, can the reflex still be present? The answer is yes, because this area is innervated by more than one level. But it does give us a good guesstimation as to the general area that might be affected. Now, if the S1 nerve root is compressed, this reflex will be affected. This is done by dorsiflexing the foot a little bit and then tapping on the tendon with a reflex hammer to induce an involuntary plantar flexion of the foot. If you test reflexes and they're decreased, this can tell us if a nerve root might be impinged or affected. An anatomical structure we referred to earlier as the facet joint is now in front of us. The function of the facet joints really allow motion in all planes. They guide motion and they restrict motion. In the literature, they're often referred to as the zygapophyseal joints, Z-Y-G-A-P-O-P-H-Y-S-E-A-L, zygapophyseal. Sometimes they're abbreviated the ZAP joints, obviously because of this long name that's sometimes laborious to say. Now, formed by the superior and inferior articular processes from the adjacent vertebra, the facets are oriented in the sagittal plane. The anterior portion is turned slightly medial, so it falls in the frontal plane. Their blood supply is really from the periarticular plexus. The alignment will allow for and restrict motion. I'd like to introduce the idea of a facet tropism as a possible imitation. What a tropism is really a bony anomaly of the facet joint. Maybe one facet joint is slightly turned in a different plane, which would restrict motion. While this is a fairly normal bony anomaly, this needs to be understood as it could be a block to motion, which wouldn't be all that abnormal. Now, just like other structures, the facet joints have a capsule, and this joint can become impinged upon. In considering facet joints, there are several structures that prevent the capsule from being pinched. One of which is the ligamentum flavum, one is the multifidus muscle, and one is the meniscus. Now, earlier on in the semester, in the beginning, we could easily see that joint capsule invaginating, so when we released our distraction on that joint capsule, we did it slowly, so we prevented some pinching of the capsule, which could lead to a synovitis. The same thing can happen in the spine. It happens much more frequently in the neck, but it also happens in the lumbar spine. The ligamentum flavum has an elastic pull to it, which essentially acts as a spring to kind of pull the capsule up out of the way of the facet joints, really the two working parts of the facet joint. Now, the lumbar multifidi have attachments on the capsule. When they are contracted, they help pull the capsule out of the way, so we can actually use these muscles to help treat this area when the capsule's been pinched between the two articular surfaces. Now, the multifidi, with guarding, it could swell and push against the capsule that may actually increase pinching. So we need to be aware that this could be something that needs to be treated. Now there is a flip side. The meniscus itself is a little bit different. It provides a significant physical block to that capsule being pinched. One problem with the meniscus is there can be some abnormal formation or extra meniscus tissue that's involved in the joint, in the facet joint. This can actually cause it to get in the way and cause the capsule to be pinched a little bit more when it actually is supposed to function to block the capsule from being pinched in the first place. This is usually a degenerative process that creates this extra tissue or meniscus. This is sometimes a difficult view with which to orient yourself to, but this is a depiction of a facet joint, really a cross-sectional view of a vertebra. Now, between the two arrows, we see the articulating surfaces of the inferior articular process to the left of the vertebra up above. To the right is really the superior articular process of the vertebra down below. Those two slide up and down on each other. The two arrows are actually pointing to the menisci. The cephalad meniscus towards the top and the caudal meniscus towards the bottom, creating a physical block to the capsule being pinched. Take some time and really get oriented to this structure. We're going to look at ligaments of the lumbar spine a little bit more closely. With respect to function, ligaments have a number of mechanoreceptors. They maintain joint integrity and allow for motion. They also prevent excessive motion unless laxity is a problem. Now, just like all other joints, the spine has a fair amount of ligaments. Mechanoreceptors really tell us where we are in space. Just like other parts of the body, the spine is not much different. They provide proprioceptive input. As we get into some of the particular problems that people experience, the first thing that I'd like to cover is ligamentous weakness and postural back pain. This is probably the most common type of back pain with the student population and people that work in sedentary professions. This typically materializes as an aching with prolonged sitting, standing, or other postures. A patient will change positions a lot to try to achieve relief, really to reduce strain on the spine. It's not uncommon to have a patient be a self-manipulator or self-crack themselves for some short-term relief. This provides some short-term relaxation of the muscles, but is very temporary. It can also create some instability if someone isn't careful. Lumbar range of motion is generally very good in this patient. There's pain at the end range of motion with a stretch, and stretching generally feels good. Hip muscles may be very tight. This may be a compensatory problem. Now, with ligamentous weakness and postural back pain, there will not be neurologic signs and symptoms. There will not be changes in dermatomes, myotomes, or reflexes. Now, this is actually a pretty serious condition because it's a pre-discal condition, and a discal condition is very serious. The only thing that turns this into a disc condition is just added time and added strain. So it's important to achieve a good posture and move often and reduce strain in the lumbar spine. Disc bulges are actually very common, and it's very common in the asymptomatic subjects. In the literature, it's estimated that up to 30 to 40% of people without symptoms actually have a disc bulge, and that's diagnosed via MRI. This is a depiction of the vertebral ligaments in the lumbar region. These joints, too, can become injured. They heal fairly slowly due to a poor blood supply. Here you have a cross-sectional view, and it's from Netter. The areas that can easily be visualized are the vertebral body, the disc, and the spinous process. We can see the anterior longitudinal ligament in number 1. Now you should note that this does not have direct attachments to the disc. If you look at number 7, this is the intraspinous ligament. Look at how these fibers are drawn from the top and going down, which seems like it wouldn't allow for much forward bending in the spine because the ligament would become taut. Now this is some of the work that's significant of Dr. Stanley Paris. This is essentially drawn incorrectly. Instead of running in the alignment as pictured, it runs superior and posteriorly. One way that you can easily remember this as the SP, as in superior, and posterior stands for Stanley Paris. What you're seeing now is a cadaver dissection of the anterior longitudinal ligament on the anterior surfaces of the vertebral bodies. Now, number 1 is on the left and number 2 is on the right. Number 1, the anterior longitudinal ligament has attachments to the anterior surface of the vertebral body, so we would expect it to limit extension. Number 2 is the posterior longitudinal ligament. The spinous processes and the transverse processes have been cut out, and we're looking really at the back of the vertebral body. What do you think this will limit? Well, what it's going to limit specifically is flexion. With the posterior longitudinal ligament, while it backs up right to the disc, it does attach directly to the disc. It stops a disc from a straight posterior herniation. The anterior longitudinal ligament has no direct attachment to the disc, although it has a great breadth of contact to it. This is another picture from Gray's Anatomy looking at the posterior longitudinal ligament. Both spinous and transverse processes have been removed so you can see the ligament a little bit better. Now in this picture you can see that there is a broader expansion where the discs reside. This provides protection really to the spinal cord, which is running right in that vicinity. Now you can see that the anterior vertebral bodies have been cut off. What you're looking at right in front of you is the ligamentum flavum, which attaches directly to the capsule, as we've mentioned earlier. And this, as you remember, prevents the nipping or the pinching of the capsule because of the elastic quality that it has. Now really this ligament typically has a yellow appearance, and that is from the elastin that actually has its yellow hue. This is really a springy type of collagen. This is an artist's rendition of the supraspinous ligament. This runs down between each spinous processes and then blends into the thoracolumbar fascia at right around the L2, L3 region. Most of these pictures come from the spine reference. What you're looking at right now is another rendition of the intraspinous ligament. Those two projections off to the right are those of the spinous processes. So in this rendition you can see that this ligament is going in a superior and posterior direction. Remember SP for Stanley Paris. It is often drawn wrong, but biomechanically it makes sense. This is a look at a cross-sectional view in the transverse plane. Here we see the intraspinous ligament, and we can see nicely how the ligamentum flavum and how it has its attachment into the capsule itself. This is really a cross-sectional view in the sagittal plane. It's putting all the structures together. Notice that the intraspinous ligament is drawn incorrectly. The arrow, of course, is the correct direction that it should be running. Here's a list of the muscles throughout the spine. The superficial muscles have a definite link from the extremities to the spine. That is really their chief role, to primarily move the extremities and tie into the spine. The intermediate muscles are really the erector spinae and the paraspinals. Their actions mostly are side bending and rotation to the same side. They run up and out. Now the deep muscles are what we're primarily interested in mostly as stabilizers. They really side bend to the same side and rotate opposite, and they run up and in. In regards to the stabilizers, the rotatories have less of a stabilizing function, but they have some increased proprioceptive muscular input into the spine. This is very important. This is a slide I'm sure you're all familiar with, and this is a picture from your Netter anatomy atlas. So it's really just a look of the superficial muscles that connect to the extremities. One thing of interest is a look at the attachment through the fascia to the spine. So you can definitely see how a problem with these muscles would cause a spine problem. And here's a look at the intermediate muscles, iliocostalis, longissimus, and spinalis. They're running up and out, as you can see. In the lumbar spine, these often have an increase in tone or abnormal muscle holding patterns that we generally palpate when examining the spine. And now you can see the deep musculature. Multifidus is the chief segmental stabilizer from the spine. So with lumbar instability, this is a key muscle to train. We're going to see some exercises later. And there's quite a bit of research by Hodges out of Australia where chronic low back pain show the multifidus is not working, moth-eaten, or has different appearances to it. There's a lot of interest in this muscle group. Speaking of the multifidus, here is a look at the multifidus crossing 1 to 2 segments running up and in. This is, again, the chief intersegmental stabilizer of the lumbar spine. Because of its bipinnate structure, it has multiple level attachments. It's a very important muscle, and you'll read about it quite a bit in the literature throughout your physical therapy education. Now it's time to look at some of the musculature that has influences on the front of the body. The psoas has an attachment to the anterior vertebral body, so of course it can influence the spine. It can very well cause an increased lumbar lordosis. You can assess this for its tone through palpation or length testing. The quadratus lumborum is an interesting muscle when it comes to lumbar stabilization. It's often an area that can also become dysfunctional. It runs from the iliac crest to the 12th rib. It can be palpated when a person's side-lying or sometimes prone. One thing that can be done to strengthen or stabilize this area is instead of doing a regular bridge exercise, you can accomplish a bridge on the side. It's really like doing a side plank exercise if you're familiar with that, but this muscle deserves some attention. The transversus abdominis, or abbreviated TA, is a very important muscle in terms of stability. It has an attachment to the thoracolumbar fascia, which will provide segmental stabilization, kind of like the multifidus. When it tightens, it really acts like a corset. It fires with the internal and external oblique in forming this corset, and actually directly fires with the internal oblique. Now, the rectus abdominis, the ones that are fired with your crunches, they'll give you the six-pack look, but they really don't have much of an influence on spinal stability. You need to do a good transversus abdominis contraction, a small contraction, without recruiting the rectus abdominis and obliques, which is pretty hard to selectively fire. Sometimes the use of diagnostic ultrasound can aid in getting a very good contraction of this area. Also, the little stabilizer pressure cuff is a good method of doing this as well. So you got to think about the transversus abdominis for the back much like we think about the knee. We're going to work the hamstrings and quads to stabilize it. So the back really needs the same attention both to the anterior and the posterior musculature. So the abs are really just the front of the back if we think about it that way. This concludes the first half of the lumbar spine lecture.